My name is Thomas KAHAN. I'm a professor of internal medicine at the Karolinska Institutet in Stockholm, Sweden, where I work as a clinical cardiologist in one of the university hospitals. My task in the presentation today is to talk about treatment of hypertension in patients with heart failure. Heart failure is a condition with a bad prognosis, and approximately half of all patients will die within 5 years. The most important risk factor is hypertension or ischemic heart disease. And although myocardial infarction has the greatest hazard ratio, hypertension is probably more important because hypertension is so prevalent. So the attributable risk for heart failure is much greater with hypertension. In a simplified manner, you can divide heart failure into two types. Either you have atherosclerotic disease, which will lead to systolic dysfunction, that is what we call heart failure with reduced ejection fraction, or we have a condition where the ejection fraction remains normal and you have a stiff fibrotic heart, which is typical for hypertensive heart disease. In the case of a reduced ejection fraction, the therapy today for heart failure is well established and actually very much in consort with how we treat high blood pressure. So basic therapy is ACE inhibitors or ARBs, beta blockers, aldosterone antagonists, and in case of fluid overload we use diuretics. And all these drugs have shown to be of benefit in heart failure, and they are also well documented blood pressure lowering agents. In the case of a patient with preserved ejection fraction and heart failure, the problem is not contractility, but rather that the heart is stiff. This is typically a condition of women, high age, and it's often accompanied with atrial fibrillation. And here we know that blood pressure control is very important, but we do not know very much if there is a specific therapy that is more beneficial than blood pressure control in general. And so far most studies have not been able to show superiority for a particular antihypertensive treatment. And again, basic therapy would be then standard blood pressure control and diuretics if we need it. However, it's quite clear that control of blood pressure will improve prognosis considerably, reduce number of new onset heart failure, and also reduce hospitalizations in patients already with established heart failure. And I think that if we can improve blood pressure control, we will definitely reduce the number of hospitalizations, which is a major concern both for the patient and for the care providers all over the world.